Okay, so this is part 3 of the high-risk newborn, and we're going to now look at the post-dates infant, the post-term infants. By textbook definition, this is a baby born after 42 weeks of gestation. They're at increased risk for hypoglycemia, for meconium aspiration, and developing cold stress, amongst other transitional problems. When you look at the post-dates pregnancy, this is going to involve more frequent NST tests, biophysical profile tests. They're going to try to determine if mom is a candidate for an induction and do we induce her. And then after birth, you're going to look at issues and interventions such as watching this baby's blood sugar, their respiratory status, their ability to maintain their temperature, and how they transition to the external uterine environment. When you look in this picture, I ask a question, and that is, what do you see when you look at this newborn baby? What I'm hoping that you see is a longer, skinny baby with dry, parched skin. You see the deep cracking and kind of peeling nature to this baby's skin. That's typically the appearance that you're going to see in the post-dates baby, where a lot of the vernix, which protects their skin from the amniotic fluid, has worn away. Their skin is in more direct contact with the amniotic fluid, and you'll see their skin be more, it's thicker and peely and more cracked in appearance. What do you see in this picture? Hopefully you see a baby who has long fingernails and fingers, but also has peeling skin. And when you look at the skin that's peeling, notice the color of the skin. I'll get into that in a couple of slides. You'll see a longer, skinny infant, dry, parched, cracking skin. Sometimes they'll even have thinner and skinnier extremities, which they have lost a little bit of their fat, but this is a typical appearance of a post-dates baby. When you see this picture, this is along with the picture of the baby's hands, are evident of a baby who was laying in meconium stained fluid, which is an increased risk for post-dates babies. And we talked about what happens to the circulation to the from the placenta being older, and the perfusion that happens to the decrease in perfusion that happens to babies that are in utero after 42 weeks of gestation. But you have meconium stained vernix. This is meconium stained vernix in a meconium stained infant. This is meconium stained umbilical cord. This is meconium stained placenta. What I'm presenting to you is, we talked about what happens when the baby is in utero for longer than that normal window, and what the decrease in perfusion causes a little stress in the fetus. So that stress response is part of their fight or flight response. In utero, their sphincters will relax and the baby will release the meconium into the amniotic fluid. For the first couple hours after birth, it floats around in the amniotic fluid in clumps, and then it will kind of dissipate, and the consistency will resemble pea soup. And then you heard me talk about pea soup stained meconium fluid when we were talking earlier this semester. And then after several days, the meconium starts to clear, but the baby, the amniotic sac, the fluid, the surrounding structures are stained. This is a post-dates placenta. The post-dates placenta has an increased risk for fragmenting, for breaking apart, and obviously because of a decreased perfusion to the fetus. So if we are concerned about perfusion to the baby in the placental age, they will start having discussions with mom about inducing her so she can deliver earlier to prevent we don't want the baby to be poorly perfused and develop post-dates problems. When you look at the assessments for post-AIDS baby, again, we talked about NSTs, biophysical profile, Bishop scoring, and induction, but look at their transitional status after. Those are before delivery, obviously, and after delivery, you're going to do some close assessments to make sure that they're transitioning from the intrauterine environment to the the external uterine environment post-delivery. Some of the complications that you'll see with the post-mature infant: hypoglycemia, meconium aspiration. They may be post-AIDS because of some congenital anomaly. They have increased risk for seizure activity and cold stress. Here are your interventions for these babies. Watch their blood sugar, watch their respiratory status, assess them for cold stress and for seizure activity. We're now going to move into the care of the preterm baby, and I do want to tell you, it's not only healthier for the baby to be born at term, it's also cheaper. I'm going to explain why it's cheaper in a couple of slides. But when you look at the preterm infant, we can be looking at a low birth weight baby or a very low birth weight baby. In addition, this baby may have IUGR. There are a variety of causes which we talked about that can bring us to this table, but preterm infants have a higher risk of mortality, and in some research reports it's pointing to the fact that preterm delivery may be linked to approximately 35% of all infant deaths. So we want to try to prevent preterm births. We want to try to provide mom with adequate prenatal care and education to reduce the high risk of antenatal conditions. And if she does have to deliver early, can we get her as close to term as possible? Can we make sure that the infant is stable as possible, and then make sure that they have a good transfer to a NICU, a neonatal intensive care environment, and that we can try immediate intervention. There's a lot more to what I'm giving you. I'm just kind of giving you a framework of the needs of your preterm baby. There are some diagnostic tests that can be done prior to birth, one of which is the fetal fibronectin test. This fetal fibronectin is present in cervical secretions, specifically between 22 and 34 weeks of gestation, and it's used to essentially assess the likelihood or the possibility of mom delivering early. What you want to understand is if the maternal membranes and the fetal membranes start to have some separation, this fetal fibronectin level will rise. It's a protein, and it represents the disruption of the decidual chorionic interfacing together. So if it starts to kind of tear away, that you'll have an increase of this level, and it's considered positive if the reading is greater than 50, which means she has an increased likelihood of delivering early. When you look at the statistics of preterm birth, the March of Dimes gives a report card for each state every year, and I'm going to give you kind of a little bit background so you can kind of see where we are now. At least to the current data that I have, which may change in a year or two. But in 2009, the country was not in a good place healthcare wise. Politically speaking, there was a lot of debate that was happening between healthcare and the need for healthcare. But in the middle of this was, which was lost on some, was the report card that comes out every year by the March of Dimes as to where we are as a nation and each state for preterm births and our stats and our mortality rates and our morbidity rates, etc. And if you look at this, 3/4 of the country, actually the majority of the country, was in the ranking of a D and F area, which was not good. And Ohio had a big fat F. Now, between 2008 and 2013, you had some changes that occurred in healthcare, one of which was the implementation of the Affordable Care Act, which made it brought us some positive results. And you can see those with the March of Dimes report card as to preterm births and the implementation of some of those interventions and some of the things that we were seeing. And Ohio went from 2009 to 2013 from an F to a C, which is a pretty good move. I mean, there's always room for improvement, but we went from a F to a C. And look at the rest of the country. You also had some areas that moved from an F to a C, and some areas moved even to the B and A category. So there was some positive changes affecting underinsured women. This may be women who have insurance, but it's not meeting all their needs, or it's kind of, think about your working poor that may have jobs, but they don't necessarily have healthcare coverage. We started to see some changes in those populations as well, and they were positive changes. We still have some problems, and one of which is 1 out of 4 women of childbearing age in Ohio is a smoker. So smoking still is a problem in Ohio. We still have an issue with late preterm births. About 1 in 11 births in Ohio is a late preterm birth, which is between 34 and 36 weeks of gestation. And that rise in late preterm births has been linked to issues of early induction, labor, and C-section procedures. And insurance is still an issue in Ohio, where access to care has not been 100% addressed. The Affordable Care Act did make some very good, it brought some positive changes, but there's still more work that we need to do. And we need to have people of childbearing age, actually healthcare in general, you need to have insurance, but healthcare access before and during pregnancy helps identify and manage conditions that can contribute to preterm birth. Now, when you look at the decisions about resuscitation and resuscitating a preterm delivery, you're entering into a kind of a highly ethical, highly charged environment, which also has some political connotations to it. And I'm not trying to step into those areas. What I'm trying to present is this is kind of an overall general approach as to what you may see. The Newfield Council on Bioethics does give a lot of direction as to what we should do about resuscitating preterm infants. When are we going to do interventions? If you're looking at a baby greater than 25 weeks of gestation, they're always going to try to resuscitate if possible. But a baby between 22 and 25 weeks of gestation, that's very, very early, and it's going to be complicated, and so they're going to look at what's happening with the baby. They're going to look at the baby's transition and how stable, and if there are problems, and are all of their organs failing, and you know, we need to stop with all the interventions. There's going to be some decisions that are going to be made, and that's typically an option between the parents and the doctor. It's going to be a case-by-case scenario. But babies that are born less than 22 weeks, when you're looking like a 21-weeker, there is really not a lot of options, and this baby is not going to likely to survive this birth. I said to you a couple slides ago that it's not only healthier for the babies to be born at term, but it's also cheaper. And there is a lot of background information to support what I'm saying to you. This is just this was a report back in 2003 and 2006, and I also compared some data from 2015, but just to kind of give you an idea of how expensive preterm birth is, it really is cheaper for a baby to be born at term. When you look at the hospital charges for all preterm babies born in 2003, it totaled $18.1 billion and has steadily increased through 2017. Preterm infants accounted for half of all hospital charges for infants at that same period of time, $36.7 billion. The average charge for the most severe stay was about $77,000 compared to the average term baby, which was $1,700. Again, it's cheaper for them to be born term and also healthier. When you look at the common complications of preterm babies, complications of preterm birth increase with the baby's gestational age and birth weight decreasing.